All right, and then I will pass this on to Molly to get the webinar started.
Hi, everyone. Thank you, Jess. Appreciate that. So we're going to start out just with a quick recap of some 2022 traditional MIPS key dates. So here's the timeline of important events, especially as we near the end of 2022 in this performance year. CMS released the prior year, the final performance data for 2021 around August of 2022. And that was released into the QPP, the Quality Payment Program, with incentive rates from 2021. I will let you know that some organizations did see a small change in their scores from 2021. If you haven't logged back in since they initially came out, there were a few little minor adjustments, specifically when CMS had included the incorrect or had scored administrative claims measures against the wrong set of benchmarks. And so when they adjusted that, most of our clients that were scored on any of those administrative claims measures did see an increase in some of those scores. So it's worth just checking back in to see if you see a higher score. CMS released the proposed rule in July of 2022, and then they released the final rule at the beginning of or in November. And then October 2nd was the last day to start a 90-day window in order to satisfactorily report on both either MIPS PI or IA categories for 2022. On the 23rd of November, CMS released the final rule, or the final 2022 MIPS eligibility, and then any other updated special statuses that go along with that final eligibility. So December 31st is the final date where you can go in and submit and apply for exception hardships. All exception hardship applications must be submitted by January 3rd. However, we are telling everybody to just lock December 31st into your brain. There are two exception applications for 2022. One is the promoting interoperability exception application, and that's been available in previous years. That allows you to have the PI category weighted to 0% based on being small, actually being having insufficient internet connectivity in there, and any other hardship reasoning. Small practices actually get an automatic reweight for PI for 2022, and so if you are small, you will get an automatic reweight for the PI category. But I will note that if you decide to actually submit PI data, you will get scored for the PI category if you're small. So that's just important to note. The second is the extreme and uncontrollable circumstances application. That's still an option for 2022 for those that continue to be impacted by the pandemic. There are other hardship exception reasons as well, but the COVID pandemic certainly falls under this rule, allows you to go in and submit an application to have one or many of the different MIPS categories weighted to 0 for 2022. And then finally, January 1 through March 31 is the MIPS submission window, and that's when basically this timeline kind of starts all over again. So before I jump into the rest of the presentation, I just wanted to take a second to give some background on what this webinar is really about. As noted in the timeline, the last slide, CMS, they release a proposed rule through July. That goes through a set of fee schedule updates, and then people make comments on that, and then CMS releases a final rule, and then that impacts the policies that go into are enacted in the following year. And so that's where we are right here. This is for the 2023 performance year, and it will cover traditional MIPS, APMs, MIPS APMs, MIPS value pathways, etc. So this is the standard category weighting structure for MIPS payment rates for MIPS years 2018 through 2023. And the thing to note on this slide is that 2022 is the last year of the exceptional performance adjustment. 2023 will only have the budget neutral payment adjustment. And we'll see that when we go through and look at the incentive rate slide. So I want to break into some of the proposed or the finalized updates for MIPS quality. The quality category under the standard scoring will remain at the weight of 30% of the total MIPS score. And it has to be reported for the entire 12-month window, the 12-month calendar year. Under traditional MIPS, you have to still report 6 measures, with at least one of them being either a high priority or an outcome measure. And following suit with CMS's commitment to improving health equity across rural and underserved communities, they did finalize a policy to expand the classification of a high priority measure to include health equity related quality measures, which is fantastic. They finalized big changes to the quality measure inventory. I'll go through all of those changes and give you a minute to kind of look through things. I'll point out a couple of measures that I really like for 2023. But within that, there was an addition of 9 measures. They did remove 11 quality measures, and they made substantive changes to 76 MIPS quality measures. Additionally, they finalized the partial removal of both the influenza and the pneumococcal immunization measures 110 and 111 from traditional MIPS reporting. They will only be offering them under the MVP pathway, and I'll show you what that looks like as well. So 110 and 111 will only be offered in the, both measures will be offered in the optimal care for kidney health MVP, and measure 111 will be offered in the advancing rheumatology patient care MVP. There is another new kind of comprehensive immunizations measure that I'll show you in the next couple of slides. It has more immunizations. It's all kind of combined into one. So that is there to consider as well for 2023. And then the data completeness of 70% will remain for 2023, which requires that at least 70% of the eligible events for each measure must be reported from the 12-month reporting window. So and CMS did finalize that they will be increasing that data completeness to 75% in 2024 and 2025. And so what I mean by that is, you know, if you have to report you have to have a reporting rate of at least 70% in 2023 and 75% in 2024 and 2025. So these are the quality measures that were finalized for removal. They had proposed that they were going to remove these. They finalized that they were going to remove them. I'd say the biggest hits for a lot of our clients are the first few measures, including also biopsy follow-up, but measures 110, 111, again, those being removed and moved over to just the MVP option. And of course, only being really offered in just a couple of those MVPs. And then also the diabetes medical attention for nephropathy, that was a big loss this year as well. Some of these measures had just been, you know, they had been capped at over the last couple of years. And then the other thing about 110 and 111 is that CMS does want people to be early adopters to MVP reporting. So there's incentive to kind of move those that really depend on the measure 110 and 111, may be more apt to move over to MVP reporting. So this is the quality measures inventory for those that were finalized for addition. And I wish I had marked these off, but I do want to mark off a couple of measures. One is the adult immunization status, and that's down here. This is for patients 19 years and older who are up to date on recommended routine vaccines for influenza, tetanus, and diphtheria, and then pertussis, zoster, and pneumococcal. And so that's a MIPS CQM measure, and the other is screening for social drivers of health. And so this is 18 years and older patients that were screened for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. I probably like this measure the most for a number of different reasons, but social determinants of health are obviously not only, a quality factor that should be considered, but over time are going to get more and more a part of your risk scoring for your patients as well. So getting into, the mode of starting to document some of these things, asking some of these questions, setting up workflows for 2023 or future years to start implementing, pushing to find out some of these things, screening for your patients for some of these things is really going to be important for a number of different reasons. Additionally, any of these measures, their first year, these are new measures. So their first year of existence, they have a point floor of 7 points. So no matter what, you would get a minimum of 7 points for reporting these. The second year of their existence, they get a minimum of 5 points. And that's a big deal. And there's going to be some other slides later on that are going to kind of show you why that's such a big deal. But having additionally beyond just the minimum 7 points for the first year, when the measures get, if enough people do report on the measure, any new measure, a performance period benchmark will be generated, and then people will then be scored against that new measure, and we'll find out if that was one of their higher scores in the final feedback that's released in the final feedback that is released in July of 2024. So while that's tough, the nice thing is that you're going to get a minimum of 7 points, but if your performance is high enough and they create one of those benchmarks, you could get all the way up to 10 points. So that 7-point floor first year, 5-point floor second year is really a push to get people, interested and moving over to new measures as well, especially as some of the process measures are getting more standard operating procedure. So not a ton of changes for the MIPS cost category for 2023. Cost will remain at 30% with standard weighting. It is 12-month reporting window. It's calculated through administrative claims, so there's no submission that's required for the cost category. If practices don't have enough cases to reach case minimums for any of the cost measures, they just won't be scored on any of those cost measures, and the points will be redistributed to other categories if none of the cost measures met case minimums. The only cost highlighted rule changed has to do with statutory requirement that CMS has to account for improvement in the assessment of performance under cost. And so basically CMS needed to come up with a way to reward practices that are improving their costs and working to improve their costs, which I'm not totally sure how that would have been possible when we didn't really know how we were doing on cost measures throughout the last couple of years with COVID anyways, but to do so, CMS finalized the max cost improvement score of 1 percentage point out of 100. And that will actually start with the 2022 performance period. So that's one change. There's not going to be anything that's going to be done other to change that or do anything about that. But what we will notice is if your cost scores did change, CMS, you'll see that when they come out with the final feedback for cost. No huge changes on improvement activities for 2023. It remains a minimum 90-day reporting window. It's worth 15% of the MIPS score under standard scoring. Small non-patient facing rural and health professional shortage area practices will continue to earn double the score for each activity that they complete, which is always still nice. CMS is certainly still very much supporting small practices across the board on MIPS policies. And just a quick reminder that in order to receive credit or score for completing an improvement activity, at least 50% of your eligible clinicians have to have completed the improvement activity during the performance period. That's a key thing that doesn't change. That's still in place today with 2022 as well. CMS removed 6 improvement activities for 2023, added 4 and modified 5. These are the improvement activities that were finalized for removal. Certainly consultation of the prescription drug monitoring program is probably the one that is the most significant to our customers. That one did go away. That was a high weighted one. So, you should be starting to pay attention to what improvement activities have been removed, what you typically report on. One thing to note with these is really understanding if you are going to, if you do have to change your improvement activities and change your workflows, understanding what the data validation criteria are that go along with that improvement activity. If CMS did come and audit you, are you going to be able to show documentation per what they suggest for documentation for the improvement activities that you take on? So that's certainly make sure that you're aware of those and what documentation you're holding for some of those improvement activities. These are the 4 that they added on for 2023. And the COVID vaccine achievement, it's interesting. One of our clients asked yesterday, is there really anywhere that CMS is starting to measure COVID or measure vaccinations or anything? And surprisingly, there was a drafted COVID measure that was drafted. I don't think it ever got past the draft point, but the only place we're really seeing COVID and management of COVID and vaccinations, et cetera, show up is here in this new improvement activity here. And that's if you can demonstrate that 100% of your office staff are fully vaccinated for COVID, that is a medium weighted activity for 2023. Okay, so for PI, starting with the basics of PI, it's worth 25% of the standard MIPS score. It remains a minimum of 90 days to up to the 12-month reporting window. CMS, oops, sorry about that. CMS did discontinue automatic reweighting of the PI category for nurse practitioners, physician's assistants, CRNAs, and clinical nurse specialists for 2023. So they will have the same reporting requirements as anybody who is currently required for under 2022 rules. They will continue to offer automatic reweighting for the other clinician and organization types for 2023, and they will maintain the application-based reweighting option as well. So for the PI objective proposals, for the public health and clinical data exchange objective, CMS modified the levels of engagement for measures. They basically combined option 1 and option 2 to include both completed registration to submit data and testing and validation into a single option. They also finalized that they will require submission of the level of engagement in addition to the yes, no for that objective. So you would say yes, no, but you'd also have the counts as well. For query of prescription drug monitoring program, if you may or may not have seen that some of your EHRs have been updating to meet some of the cures rule, but they're also showing you now the count of query of prescription drug queries that happen, the counts of those in your system, because now you do need to actually report the count of times that it was queried. And that makes the measure worth 10 points. The measure will include exclusion options, but it is a required measure as well for 2023. They also expanded the scope of the query, that measure to include Schedule 3 and Schedule 4 drugs in addition to Schedule 2. For the health information exchange objective, last year CMS added the bidirectional option to that objective. For 2023, they are adding a third option for participation in the Trusted Exchange Framework and Common Agreement, or TEFCA. TEFCA outlines a common set of principles, terms, and conditions to support the development of a common agreement that would help enable nationwide exchange of electronic health information, and that's across disparate health information networks and systems. And I did want to show you Here we're just showing a PI scoring example, and we also highlighted where all the changes have really taken place. I described the changes to the query of prescription drug monitoring. If you were going to report under health information exchange, the two sending health information and receiving health information, that's HIE 1 and 4. The scoring for those went to 1 to 15 points now. It used to be 1 to 20 points for each of those. The bidirectional on its own, if you went that option under HIE, it would be 30 points. And then the third option is participation in TEFCA. That is a yes or no, and that's 30 points as well. So you can pick option 1, option 2, or option 3. And then for provide patient electronic access, as long as none of the other measures are reweighted, that measure is worth 1 to 25 points going forward. And the public health and clinical data exchange, immunization, registry reporting, electronic case reporting, that's worth 25 points. So wanted to go through a few key takeaways for 2023 MIPS, traditional MIPS. For large practices, this is a big one. The 3-point floor has been removed from quality measure scoring in 2023. So large practices will receive 1.0 to 10 points if they, as long as they reach minimum data completeness criteria of 70%. So their reporting rate has to be at least 70%. They have to reach minimum cases of 20 cases or more. And if they don't, and if the measure doesn't have a historical benchmark, those large practices will receive 0 points for measures. So to get scored, first of all, it changes from having a 3-point floor to a 1-point floor. And then additionally, any measure without a historical benchmark, any measure that you don't have 70% or more data reporting rate, any measure that you don't have 20 cases, you're going to get 0 points. And then one of the big things, especially as they start modifying and changing that scoring so that it has a 1-point floor, but we're seeing it this year as well. After CMS got rid of the end-to-end and high priority bonus points, it really had an impact on scores. And we think it's really important to share what has led to a lot of success across of our clients. I think our average enterprise level clients achieved an average score of I think it was like 94 in 2021, maybe more, maybe higher than that. I know it was about 50% of them achieved a perfect score of 100. And to do that, it's really about, maximizing, understanding how they can get scored on what we consider these kind of dual version measures. So measures that have both a registry version and an EHR version. And it's about understanding, the scoring that you're going to achieve under each version, maximizing points. You can see here that the registry version of this measure in 2022 has this line where up until, a performance rate of 60 or so points, it's going to be best to report on the registry version. But once you get beyond that, the ECQM version becomes the top measure to select. So having the ability to maximize scoring and offer this to our clients has been a key factor. And I want to show you a client use case here where this is an actual client. It's 2022, but it gives you the same idea where essentially we show the points that they're achieving. And yes, they are reporting on this many measures. The points that they achieved, the ones that we believe will get scored. So it's first the registry version of the measures and those points, the EHR versions of the measures and those points, the optimal, and we have that option because Reporting MD is not only a qualified registry, but our TOM application is also ONC certified EHR technology module that allows us to offer the ECQMs as well. Any of the EHR measures that you can get in your EHR, we can also offer, we can report for you. And so we can offer you basically the ability to optimize and select the best version of each measure, depending on how your performance pushes or goes. And what that allows you to see here is if you were to report just the MIPS CQMs, this practice would get basically an 88. If they just report the EHR, 71.5. But by choosing and having that ability to pick, the best version of each measure, we're getting their score up to 92.5. So huge difference in terms of scoring. And when you're starting to deal with, 1 to 10 points, and in some cases 0 points for measures that don't have a benchmark, having this ability to pick and choose the best is key. It is absolutely a game changer for our practices. So to avoid a MIPS penalty, this is not easy. Even for me, I know that this is not easy, but to avoid a MIPS penalty for 2023, you have to reach a 75 MIPS score. There's no longer an exceptional performance bonus, and really, performance on quality measures continues to be a critical piece to MIPS success. Especially after those bonus points went away, having the ability to select your measures and which version of the measure you're scoring to optimize points is huge. Keeping all those things in mind is really important. So here, let's just take a minute to review the possible MIPS ROI for 2023 based on the final rulemaking. And so based on final policies, I think in the proposed rule, the incentive rate got up to 6.7. Based on final rule policies, they have it down. If you have a perfect score, you're getting basically a 6% adjustment. So this is the CMS scaling version. So it could reach up to 6% with a perfect score of 100. If we go back to the basics on the penalties and the incentives, there's a penalty and there's a budget neutral incentive, and both of which are applied to any claims that you're getting paid on 2 years after the performance year. So for 2023, the adjustments will be applied on claims that are paid basically throughout all of 2025. And the penalty is applied if a MIPS participant either doesn't report anything or reports and reaches a MIPS score of less than 75 in 2023. The budget neutral incentive is where essentially the incentives are paid based on the amount of penalties from practices that didn't meet the avoid penalty performance threshold or didn't report at all and didn't submit a hardship application or anything like that. So any of that penalty money goes into a pot and pays out the incentives. And so if we use the CMS scaling estimates, a score between 0 to 74.9 is going to result in a penalty of -9% up to -0.1%. The closer your score gets to that 0 neutral adjustment level. And then at 75 points, there's a neutral payment adjustment, and then 75 to 100, that would result in what CMS is estimating at 0.01 to up to 6% incentive. But now, of course, we know that the MIPS program has failed to meet the incentives originally laid out in the macro legislation, and furthermore failed to even reach the scaled versions of what CMS has anticipated each year. And part of that is due to the political backpedaling. I saw that more before COVID, a little bit now, and part of it was due to the pandemic. A lot of it was due to the pandemic and continues to be due to the pandemic. So regardless of why reporting MD, we can offer MIPS participants a reasonable idea of incentives and potential program ROI. And we want to do that based on some form of fact-based information from CMS or from historical information. Some of our clients ask us to essentially rescale prior year finalized incentive rates based on the current performance thresholds, if that makes sense, and use that for their scaling, for their ROI, so that they can continue to have goals, and even goals that utilize revenue estimates and revenue increases that they can get to. If they close 10 gaps, it's going to bring in an additional $20,000, but they like to use that based on historical finalized incentive rates. But here, we wanted to give those that don't want to use that, they want to use what CMS is scaling or estimating, or they want to use some kind of a reasonable guesstimate, we'll say. So we essentially took what CMS had estimated in prior years from 2017 through to 2021, compared that against the finalized incentives, and essentially, across those years, CMS reached 52% of what was estimated, according to their rulemaking. So, we have some things to work with, but again, it's not an exact science. Sometimes it's just about having a number there that we can say, this closing this many gaps or improving to this level of performance is going to bring in X dollars. Sometimes having that there is enough to move the needle. We'll go with that. The 2023 alternative to MIPS is the MIPS value pathways. And so if we dig into that, it is going to be it is started, or it is finalized to actually start in 2023, which is the good news. So they're not backpedaling on that so far. So it's slated to begin now. It will in 2023. It is voluntary for years 2023 through 2027, or 2028. And so actually, so it's through 2027. So starting in 2028, MVPs, there's a potential that it could replace the traditional MIPS entirely, but there's no sunset date that's currently been set. So MVPs is right now, anybody who's starting to look at reporting MVPs isn't going to be considered an early adopter. It's a new framework. It moves closer to an aligned set of measure options that are more relevant to a clinician's specialty. So it aligns measures from all the 4 different MIPS performance categories, and the framework aims to provide more meaningful data and feedback to clinicians and patients by comparing performance of like clinicians, like specialties against each other, and then enhancing, the information to patients about the quality of the care that they're getting from their providers as compared to others in the same specialty, et cetera. So the current timeline is for 2023, 2024, and 2025 performance years. MVP participants are identified as individual clinicians, single specialty groups, multi-specialty groups as well, subgroups, and APM entities that are assessed on an MVP for MIPS performance categories. For 2026, right now, multi-specialty groups will be required to form subgroups in order to report MVPs. When I say for right now, we never know if CMS is going to actually make that change, but if in 2026, any multi-specialty group has adopted and wants to continue to report on MVPs, they will have to form subgroups in order to report MVPs. And I'll show you kind of what that looks like. CMS is aware that there are a lot of types of MVPs that are still needed to develop and transition. Working with your registry or groups to identify new MVPs that you think are worthwhile can always be introduced to CMS as well. And then that goes through the whole rulemaking process. So reporting requirements for MVPs. For quality, participants will select 4 quality measures available, and one of those measures has to be an outcome or a high priority measure. In the registration process, if you wanted to report one of the outcome measures that CMS has, you would identify that during that process, but there are other outcome-based measures that you can choose from as well. For improvement activities, participants will select just two medium-weighted improvement activities or one high-weighted improvement activity. So essentially they have the same improvement activity requirements as small practices do now under traditional MIPS. So it's just a little bit less. Or they can report the improvement activity participation in a patient-centered medical home if that activity is available in the MVP. For cost, participants will be calculated on the cost measures that are included in the MVP, and that's defined within the MVP and available now if you're interested in seeing those. And some of the MVPs only have, one cost measure, for example. For the foundational layer, which is MVP agnostic, participants have to report on one population health measure, and for PI, participants will report on the same PI measures required under traditional MIPS unless they qualify for reweighting. And subgroups will submit PI data at the group level, not the subgroup level. So if you do choose to submit as a subgroup for an MVP, and it's just a smaller selection of providers in your organization, do note you're not just reporting the PI for just those providers, you're reporting it at the TIN level if you're reporting group level data. I hope that was clear. When reporting MVPs, the participant must register. They plan to report, they have to register for the MVP that they plan to report for 2023, and they won't be able to submit or make changes to the MVP they selected after the close of the registration period. And right now that's set to open on April 1st of 2023 and will close on November 30th. So it's a whole new timeline that we all need to remember. But that registration window is available then if you're interested in reporting on an MVP. To do so, at the time of registration, you'll identify which MVP you're reporting on. You'll identify one population health measure included in the MVP, and you'll identify any outcomes-based administrative claims measures on which the that you want to get scored on. So there's a couple out there, and then they just vanish from my brain. So, but that will be an option. Again, you can look at any of the MVPs now and you can see what the selection of measures are to choose from within that process. To report as a subgroup, and again, multi-specialty practices, if they're going in this direction in 2026, they should be gearing up or at least starting to think about reporting MVPs as subgroups. They don't have to do it now, but in 2026, it is going to be mandatory. But to do so, they have to identify the MVP that they're reporting on, each subgroup is reporting on, identify the population health measure, outcomes-based administrative claims measures that they want to report on, and then they have to identify the clinicians in the subgroup by TIN and PI combo that are going to be included in that subgroup. And then they provide a description of the composition of the subgroup so that they can kind of know who, maybe it's a specialty description, but that's going to be used to describe the subgroup and why they're reporting. CMS will assign a unique subgroup identifier that'll be separate from the individual NPI identifier, the group TIN identifier, and the MVP identifier. And then that's gonna likely be included in the submission, which we do across the API to CMS via JSON, but you would need to take note of that identifier for the subgroup. Important to note, subgroups do inherit the eligibility and special status determinations of the TIN. So if the TIN is health professional shortage area, then the subgroup would also be health professional shortage area. If the TIN is, whatever it is, the subgroup would inherit that. And CMS will limit subgroup reporting only to clinicians reporting through MVPs or the APP. CMS also finalized to change the way they determine single specialty practices from multi-specialty practices. So they originally had said that they were going to use the PAYCO system to do that. So when they're getting ready for that 2026 year where the multi-specialty practices have to submit subgroups if they're going to report via MVPs, CMS is going to define those multi-specialty practices through Medicare Part B claims. So that's one thing to note. And I think that's it. So here's an example of how it works to report on an MVP. I'm just going to show you the Advancing Cancer Care MVP in 2023. So, I would go register between April and November. I'd select the Advancing Care MVP. During the registration, I'm going to select my population health measure. I'm going to select my administrative claims outcome measure if there's one in there. I know a lot of people do well on like the total knee replacement. Complications from total knee or total hip replacement for some of the other ones, but each MVP has a selection of population health measures to select. So if I wanted to, or population health or administrative claims, so if I wanted to select those, I could do that at that time. And then for quality, I don't need to decide on which 4 quality measures I plan to report when it's at the time of registration. But let's just say, for example, I pick these 4 measures I want to report on. It's important I know which quality measures I'm going to report on, because I'm obviously going to be tracking performance and pushing for improved scores throughout the year. For IA, improvement activities, I don't need to decide on those at the time of registration either. I chose these 2 improvement activities, for example. For PI, my practice will report the PI as the same as is done under traditional MIPS for the group. For the population health category, I chose to report the hospital hospital-wide 30-day all-cause unplanned readmission rate for clinicians, and that'll be scored through the administrative claims. For the cost category, I missed that one. That was total per capita cost. That's the only cost measure that's included in this MVP. And then I went through population health. So that's just an example. Again, when you're doing registration for just MVP level, you're doing you're selecting some of this stuff, but most of it is about just reporting, kind of similar to how you have with traditional MIPS throughout the year. There seems to be a lot of confusion around subgroup reporting. And so I just wanted to give a few examples to give it a little bit more clarity to subgroup reporting. Essentially practices that have, multi-specialty practices could break up providers, according to their specialty and say, oncology, primary care, and cardiology might want to report on this set of, or this might want to report as a subgroup on an MVP. And then another set of providers could report on another as a subgroup and report on a different MVP. So that's kind of the way that they're doing it here. If you feel in your organization it's reasonable to break your providers up according to however you want to break them up, this might be a good option for you. The key with MVPs is really about creating apples to apples comparisons and performance benchmarks that are really comparing, those that how you practice against your peers. So that's the goal here. And subgroup reporting, again, multi-specialty practices, if they want to report MVPs in 2026, they have to choose subgroups and break their organization up into subgroups. So this is the list of the both the finalized from prior to 2023 and the final rule finalized MVPs for 2023. These are all of them. I believe that there's 11 MVPs that are out there. Not a ton to choose from. In fact, I was kind of surprised that this is the selection that has been finalized. But early adoption doesn't hurt. The nice thing about MVPs is you can also choose to report MVPs and traditional MIPS at the same time and just kind of get used to the process if you want. And I'm going to fly through the next couple of slides because it's getting late and we want to have some opportunity for Q&A. Proposed changes to alternative payment models. The final rule finalized a change for advanced APMs to remove the 2024 expiration of the 8% minimum on the generally applicable nominal risk standard for advanced APMs, and now that 8% is permanent. So to understand what the nominal risk standard is, an APM entity has to take on more than a nominal payment risk for years when the APM entity's actual expenditures under Medicare or other payer advanced APM exceed when they exceed its expected expenditures by more than nominal risk. So for example, Medicare advanced APMs, CMS is proposed to make, or CMS finalized to make permanent that rule that the minimum total amount an APM entity puts at risk has to be at least 8% of the average estimated total Medicare Parts A and B revenues of all providers and suppliers participating in that APM entity. Clear as mud. So this is applicable to those participating in MIPS at the APM entity level. It allows those participating in MIPS at the APM entity level to report the PI category at the APM entity level instead of just the TIN level, which is where it's been with most of the policies over the last couple of years. APM entities can still they can still choose to report the PI category at the individual or TIN level, but it has also been finalized that they could report at the APM entity level going forward as well. I'm sure many ACOs and APMs are relieved to hear that. CMS is maintaining sunsetting the web interface for Medicare Shared Savings Program for after 2024, and that means that in 2025, regardless of if an ACO entity is made up of 15 different organizations with 25 different EHRs and billing systems, it doesn't matter. They're still going to have all that data aggregated across those systems so that they can report accurately on all payer patients for 3 MIPS CQMs/eCQMs. And again, that's slated for 2025 requirement, data to be submitted in 2026 at the Q1 of 2026. So we're not seeing any faltering or any backpedaling from CMS on that one so far. And so just a quick slide here. We believe that strategic partnerships with our client practices is the best way to create value across a lot of these value-based care programs in the spectrum. We're very lucky to have the great clients that we have, the great customers that we have that are really interested in maintaining a level of quality that's impressive. It impresses me every day, and we love to strategize with them. So if you have any questions for us, for our sales team, or for this, please feel free to put anything into the chat. But you also have Jess's email address here as well. Jess, I'll turn it back over to you.
Yes, awesome. Yeah, thank you, Molly. So yeah, we do have a few questions for you. Let's go ahead and start. What are the requirements for critical access hospitals?
Yeah, so it kind of depends on how you're billing. My best recommendation, one, is to set up a QPP account, security officer, but also you can always go to the link that I think has been put into the chat box. That's the eligibility, and you can see if if your critical access hospital is MIPS eligible at the TIN level. But that QPP portal, it took a lot for me to say that, especially after IACS, if any of you remember IACS, that system from CMS for so many years was so tough to deal with. But when CMS came out with the QPP portal and the QPP website, it was fantastic. It was very impressive. They worked really hard on it, and it's one of the best government sites I think there is out there. So it's full of information, and having access to the portal, logging in, you can see all the information on past performance, current eligibility. You can see how eligibility changes, individual provider eligibility, etc.
Let's see. Will there be an opt-out for 2023 like they had for COVID?
Yeah, so news update as of yesterday. It was our prior understanding that the sweeping COVID pandemic hardship application where you can go in and apply to have one or all categories reweighted was only going to be available as long as the public health emergency was in place for COVID. And that ends on January 11th of 2023. And so that's what we understood from the final rule up until yesterday when I was in the registry support call from CMS, which is a mandatory call we do every month. And it turns out that the COVID pandemic hardship is going to continue to be offered in 2023. It's, you know, it's good for those that are really still suffering under the pandemic or from the pandemic, that they can opt out or have categories reweighted. It's not good for the practices that continue to work hard at quality. And it's not a small job. It's not an easy job. And these measures are changing every day. The benchmarks are changing. It's tough and they're working really, really hard. So, you know, as long as we can help them to get the highest number of points, but that option is still available for 2023 as well.
Is the 1% cost incentive applicable for those of us who reweighted cost in 2022 and or 2021?
Yeah, to be TBD. My understanding is that yes, if they're the only way that it could be is if they're scoring everybody against the 2019. So if you were scored on cost in 2019, and you showed improvement, then you would be able to benefit from that. That was a MIPS wide automatic change. Like there was no, even if you had gone in and applied to have cost reweighted in 2021 or a prior year, it was automatically done across everyone anyways. So really the only way that they could do this is if they're comparing it against 2019. So if you were scored in 2019, my guess is, and you improve your cost significantly in 2022, my guess is that you will see an improvement score.
If we participate in an ACO, will it be up to the ACO if we do MVP?
Well, to tell you the truth, it probably is going to depend on the ACO. My guess is that, you know, it's about finding out from the ACO what they're going to allow, but yeah, I think that's probably it. And it also depends on how, you know, which ACO, which model you're in. But I would certainly reach out to your ACO and find out what their plans are for MVPs.
For a large multi-specialty group, if participating in MVP and subgroups are created, how do you report as a group, or does everyone report as individuals?
So yeah, this is one of those ones that, especially at the beginning, that I was like, how is this going to work? But if you remember, I'm not going to go back to the PQRS days, but I think essentially what, you know, in the same way that you can currently report traditional MIPS reporting at the group level, and maybe you're reporting on 6 measures, and let's just say that your ENT group doesn't have any eligible patients that fall into any of the denominators for any of the 6 measures that you're choosing to report at the group level, but that those ENT providers are still they're still going to get the same adjustment that your organization gets based on the performance from the 6 measures, regardless of the fact that they didn't have any inclusion in those measures. It's going to be the same way with MVPs. So if you choose to report the advancing care MVP, you're going to report at the group level. You can report at the group level for the MVP, and you would report, however, everybody who has, if you were reporting your whole organization, anybody who has eligible events under any of the measures that you're planning to report on, everybody in the organization would get covered. You're just reporting on the measures that are in that MVP. Whoever's included, whichever providers have eligible events in the measures included in that MVP, that's just the data that gets submitted, but it represents kind of your whole organization. And that's why CMS is having that requirement in 2026, that they're moving to requiring multi-specialty groups to form subgroups, because they don't want you to get away with, you know, let's just say you have a fantastic oncology group and you report the advancing cancer care, and that represents your whole other organization. They want you to break up, everybody into the different specialty groups in order to report in 2026, so that everybody's kind of reporting on what they specialize in. I hope that's clear.
Does the taxonomy of the provider in a subgroup have to align with the MVP? For example, could an endocrinologist be grouped in with promoting wellness?
I think today, yes, as long as the providers that are included in your group have eligible events enough that you're going to meet case minimums, data completeness on the measures that you're reporting at, so that you can get scored for those measures. Because remember, you still are going to be subject to any of the decile scoring and everything like that. So if you don't have cases enough to get scored against the deciles or against the decile benchmarks, then you're not going to get scored for those measures. And if you're reporting on that MVP, you don't get scored, everybody in the organization is still going to get that bad score. So yes, you can certainly have those endocrinologists in the group, but remember, you want to be reporting on whoever you have included in the group to report on that MVP. You want to make sure you're going to be able to get those case minimums, get the highest possible score across the categories.
Right, and then just I think one more question. Do you work with oncology practices?
We do. We work with some of the best oncology practices. They're some of my favorites to work with. And but we also work with about 40 other specialties and several multi-specialty organizations as well as faculty physician organizations, very large, one of the second largest primary care organizations. I think there's 400 or 500 primary care providers, but yep, we kind of cross the gamut.
All right, well, if there are no other questions at this time, again, thank you to everyone for joining us today. Thank you, Molly. Again, if there are additional questions, please feel free to reach out to me at jraymond@reportingmd.com. And then as mentioned in the chat, I will send out a PDF version of the presentation to everyone, and then the presentation in full will be available on our website as an on-demand webinar. So again, thank you everyone again, and happy holidays.
Bye.